Welcome to the e-textbook of echocardiography, the module on aortic coarctation. Coarctation amounts for around 6 to 8% of all forms of congenital heart disease. It will represent a stenosis of aorta at the point of ductal insertion with a prominent posterior infolding. Sometimes the stenosis can be very discrete at the periductal region, or it may be extensive and involve the aortic isthmus and aortic arch. Rarely coarctations can involve abdominal aorta, mid-thoracic aorta, or ascending aorta. Coarctations are grouped as simple coarctation and complex coarctation. Simple coarctation refers to coarctation that occur without any important intracardiac lesions. Presence or absence of a patent ductus arteriosus will not influence the diagnosis of simple coarctation. A complex coarctation will be coarctations with any important aortic intracardiac pathology, which may be either a ventricular septal defect, transposition, toxic being anomaly, tricuspid atresia, AV canal, or any other intracardiac defect. One of the common association of coarctation is ventricular septal defect. A malaligned VSD with posterior deviation of the coronal septum and significant left ventricular outflow tract obstruction is very often associated with coarctation. Bicuspid aortic valve is seen in a majority of patients with coarctation. Some of the associations in a complex coarctations are shown complex, where there is a mitral stenosis caused by supramitral ring, congenital mitral valve hyperplasia or dysplasia, short dysplastic chordae, single parachute papillary muscles. Intracardiac complex abnormalities can be AV septal defect, transposition, tricuspid atresia, toxic being anomaly, and corrected transposition. Coarctation is also an important component of hypoplastic left heart syndrome. Coarctation may be associated with many macrovascular and microvascular abnormalities. Left subclavian artery may arise at the region of coarctation. Sometimes the origin of the left subclavian artery may have stenosis also. Aberrant retroesophageal right subclavian artery below the level of coarctation as the last branch is seen in about 5% of the cases. In these patients, the right arm pulse also will be feeble clinically, and so to diagnose coarctation, we need to observe the bounding pulses in the carotids. Subclavian steal syndrome caused by a steal of the blood in the circle of Willis to a subclavian artery that is arising at or below the level of the coarctation may sometimes be seen. In the circle of Willis, saccular berry aneurysms can occur in about 3 to 5% of the cases. Coronary atherosclerosis is more accelerated in relatively younger patients with coarctation. Coarctation may be associated with syndromes or dysmorphism in up to around 25% of the patients. The most common chromosomal abnormality is the Turner's syndrome. During the course of routine echocardiography, we should be able to pick up many subtle echo findings which may make us suspect the presence of coarctation. They include a low velocity abdominal aortic pulse Doppler trace, unexplained jets of mitral regurgitation, unexplained left ventricular dilatation, left ventricular hypertrophy, or left ventricular systolic dysfunction, unexplained pulmonary arterial hypertension, a very high velocity mitral regurgitation jet. If you are getting a jet which has got velocities of more than 6 meters per second, mild flow gradients in the mitral or aortic valve pulse wave Doppler, and presence of a bicuspid aortic valve. When the abdominal aortic pulse Doppler trace is attenuated and the peak systolic velocities are much less, we should suspect of presence of proximal arch obstruction. This assessment of the pulse wave Doppler signals of abdominal aorta is done from the subxiphoid view. We have to keep the cursor on the abdominal aorta in the subxiphoid trace and look at the pulse Doppler trace. And an unexplained left ventricular dilatation also may be a very subtle indicator of presence of a coarctation. Mild mitral inflow gradients may also be an indicator of the presence of coarctation. We can observe a peak and mean gradient of around 10 and 6 across the mitral valve in this example. Similarly, a mild flow acceleration in the aortic outflow may also be an indicator. Left ventricular outflow tract gradient is around 26 millimeters of mercury, amounting to 2.5 meter per second velocity in this example. Left ventricular hypertrophy may be assessed on an M mode. In this patient who was only about 8 months of age, we can appreciate the interventricular septal dimensions and the posterior wall dimensions much more thicker than what is normally expected of the age of the patient. Unexplained pulmonary arterial hypertension will also act as a point of suspicion for presence of coarctation. Unexplained mitral regurgitation, presence of a dilated and thickened left ventricle may all act as clues. In this high parasternal long axis view, we can notice that there is a mild flow turbulence across the aortic valve. This also will be one of the clues. Thickened left ventricle with reduced left ventricular contractility associated with dilatation of the left ventricle may also act as a clue. The reason why all these subtle findings are repeatedly stressed is because coarctation may be missed if the suprasternal echo window is very poor. The anatomical coarctation classification will be type 1, which is a discrete coarctation, where there is a normal sized aortic arch and a normal sized isthmus. A type 1 discrete coarctation can be with or without a PDA. The complex type 1 coarctation are classified as 1A if there is a presence of a ventricular septal defect, and 1B if there is presence of more complex abnormalities like AV septal defect or TGA or tricuspid atresia. Isthmus is a part of aorta which is distal to the left subclavian artery and proximal to the region of the coarctation. In type 2, this isthmus is also hyperplastic along with the coarctation. Once again, type 2 can be present with or without a PDA, and type 2A will refer to coarctations which are associated with isthmic hyperplasia and presence of a ventricular septal defect, and 2B will be more complex diseases like AV septal defect or transposition. Type 3 is much more extensive involvement of the aortic arch, so there will be a coarctation with isthmic hyperplasia and also a distal arch hyperplasia. Again, type 3 can be present with or without patent ductus arteriosus. Type 3A will refer to arch and isthmic hyperplasia with coarctation in the presence of a ventricular septal defect, and 3B will be the more complex abnormalities like TGA, Taussig Bing anomaly, AV septal defects. Amato 1 classification refers to a very discrete coarctation. There will be a posterior aortic shelf and a significant coarctation. The isthmus which refers to the portion of aorta beyond the left subclavian artery up to the coarctation, will be reasonably well formed. In this suprasternal long axis view, we can appreciate the size of the isthmus almost comparable to the size of the transverse aortic arch. On a color flow imaging, we can appreciate the laminar blood flow in the entire transverse arch and in the isthmic area, and the turbulence starts only at the level of the discrete coarctation. Sometimes the coarctation may be present immediately after the left subclavian artery origin, in which case the isthmic segment will be shorter. However, we can notice that even though the isthmic segment is shorter, the lumen is adequate, and so this will be an example of a discrete coarctation. We can notice that the pre-coarctation short isthmic segment is well formed. However, there is a tight discrete coarctation. The coarctation gradients will extend into the diastole, and the diastolic tailing is a feature of significant coarctation. We have a maximum gradient of around 84 millimeters of mercury and a mean gradient of around 38 millimeters of mercury in this example. Whenever the mean gradients are more than 20 millimeters of mercury, a coarctation is clinically very significant. Some of the discrete coarctation may be thin membranous in morphology. In this example, we can see in the long axial view of the aortic arch, a well-formed aortic arch. We can appreciate the left subclavian artery as the last branch. We can appreciate a very well-formed isthmic segment after the left subclavian artery. There is a thin membranous obstruction which causes a discrete coarctation. And in the sweep, we can also appreciate a patent ductus arteriosus that is seen immediately below the coarctation. So this will be an example of amato 1, type 1 coarctation, where the coarctation is not only discrete, but is very thin and membranous in its morphology. On a frozen frame, we can appreciate the thin membranous obstruction coming off from both the anterior and posterior walls of the aorta. This type of morphology is quite rare. On these frozen frames, the dimensions of the aorta are taken. The transverse aortic arch measures about 14 millimeters. The isthmus also, on eyeballing, measures more or less similar. The coarctation diameter is about 5 millimeter, and the post-coarctation descending thoracic aorta, which is often dilated, is about 18 millimeter. Amato type 2 coarctations are those which are associated with hyperplasia of the isthmus. The portion of aorta beyond the left subclavian artery up to the coarctation, which is called as the isthmus, is narrower than the aortic arch. We can notice that the transverse aortic arch is well formed. However, the isthmus measures only about half the diameter as the transverse aortic arch. The presence of isthmic hyperplasia is very important to notice on echocardiography, since it will change the surgical and interventional plans. If there is an isthmic hyperplasia and a patient is going for surgery, he should have an extended end-to-end anastomosis or a left subclavian flap aortoplasty. Similarly, if a patient is going for an intervention and if there is an ischemic hyperplasia, he may have to go for a stenting of the coarctation because the results of simple balloon dilatation in the presence of ischemic hyperplasia is not very long lasting. In a color compare mode, we can appreciate the ischemic hyperplasia. We can notice that the diameter of the isthmus is roughly half the diameter of the transverse aortic arch. Diastolic tailing of the signal is the rule in any significant coarctation. We should measure the coarctation gradient in the entire cardiac cycle. When a patient is having a substantial bradycardia due to concurrent beta blocker therapy, we will notice that the diastolic gradients almost touches zero in mid to late diastole. Amato type 3 coarctation will refer to coarctations that not only have ischemic hyperplasia but also distal arch hyperplasia. We can appreciate in this long axis suprasternal view of the aortic arch a well-formed ascending aorta giving off the first two branches, innominate artery and the left carotid artery. Immediately after the left carotid artery, there is a significant narrowing of the aortic arch, and this left subclavian artery, the last branch, arises from the narrowed portion of the aortic arch. The aorta continues as a narrow isthmus and then ends up in a tight coarctation. This diffuse aortic arch and ischemic narrowing is a feature of Amato type 3 classification. A magnified view of the same picture shown in the previous slide. We can notice that the diameter of the transverse aortic arch immediately after the left carotid and before the left subclavian is much less than half the size of the ascending aorta. All these types of coarctation, whether it is type 1, type 2 or type 3, may be associated with a patent ductus arteriosus. Whenever there is a patency of the patent ductus arteriosus, the gradients across the coarctation will be marginally be lower. We can appreciate in this patient that the mean gradients are only about 14 millimeters of mercury. However, there is a significant diastolic tailing which will indicate a diastolic gradient between the ascending aorta and descending thoracic aorta. In the presence of a large patent ductus arteriosus, we can even notice a flow reversal in the descending thoracic aorta. On this subxiphoid short axis view, we can notice there is a flow reversal in the entire descending thoracic aorta shown by a blue color. In some of the patients, the ductus can be very large and associated with bidirectional flows. We can appreciate a hugely dilated main pulmonary artery giving off a ductus arteriosus which fills the descending thoracic aorta. On a magnified view of the ductus, we can notice a truly bidirectional flow with systolic flow from the pulmonary artery into the descending thoracic aorta and the diastolic flow from the descending thoracic aorta back into the main pulmonary artery. Let us evaluate this coarctation. We can see the ascending aorta, the two last branches, the left carotid and the left subclavian artery. The transverse aortic arch is very well formed. The post left subclavian portion of the aorta, which refers to the isthmus, is narrowed and then it ends up in a tight coarctation. So this will be an example of Amato type 2 coarctation without a ductus arteriosus. When we analyze every patient with coarctation, we should notice whether it is discrete, whether it is associated with hyperplasia of the isthmus, or is it associated with hyperplasia of the aortic arch also? This will be possible only when we freeze the frame of aortic arch in systole and measure all the segments. We can notice in this example that the coarctation diameter is around 3 mm, the isthmic dimension is around 4 mm, and the transverse aortic arch is much larger. Whenever there is a long tubular narrowing of the aortic arch, as seen in extensive isthmic hyperplasia, there can be a very high peak systolic signal across the coarctation. Here in this patient, we are getting a maximum velocity of around 108 millimeters of mercury. All the tubular narrowings of blood vessels will tend to exaggerate the Doppler derived peak gradients. Coarctation may be associated with aortic valve pathology, and when there is a severe aortic regurgitation, there will be a lot of flow reversal in the isthmic hyperplasia and in the arch hyperplasia. In this example, we can notice a moderate sized patent ductus arteriosus and a total flow reversal of blood flow in diastole across the isthmus and transverse aortic arch. This was caused by the presence of a very severe aortic regurgitation. The term pseudo-coarctation refers to tortuosity of the aorta, which causes a Doppler-derived gradient. However, there will not be a true pressure gradient between the ascending aorta and descending aorta on clinical examination. We can notice the turbulence on color flow Doppler across these tortuosities of the aorta, and this is defined as pseudo-coarctation. We should diagnose a tortuous aortic arch and a pseudo-coarctation whenever there is no clinical aortic gradient, but echocardiogram shows a turbulence across the aortic arch. Surgical repair of coarctation is done by end-to-end anastomosis or extended end-to-end anastomosis. Sometimes the left subclavian artery may be sacrificed and utilized in the coarctation repair in the form of subclavian flap aortoplasty. This is a post-surgical coarctation repair patient where the left subclavian artery has been utilized in the repair of coarctation. Newborns who have coarctation with associated isthmic hyperplasia will often be repaired by left subclavian flap aortoplasty. This is an example of a patient who had a recoarctation after a subclavian flap aortoplasty. We can notice that after the left carotid artery, there is no further branches for the aortic arch and there is a tight coarctation. A magnified view shows the cicatricial fibrotic anastomotic obstruction which causes a recoarctation. Whenever a newborn with severe coarctation goes for any form of intervention, the chances of recoarctation is very high. Recoarctation after surgical repair of a neonatal coarctation will be about 30%, and chances of recoarctation after an interventional balloon dilatation of neonatal coarctation will be about 75 to 80%. Whenever there is an arch hyperplasia along with coarctation, an extended end-to-end arch anastomosis is done, and this is an example of a patient who had an extended end-to-end arch anastomosis. We can notice that the descending thoracic aorta is almost anastomosed to the undersurface of the mid-transverse arch. When neonatal coarctation repair of an amato type 3 coarctation is done by an extensive arch repair, Still, there is a possibility of recurrence of coarctation, and this is a recoarctation of a patient after an extended end-to-end anastomosis. The mechanism by which balloon dilatation acts is by creating small intimal tears. In this transverse arch coarctation, which was palliated with a balloon dilatation, we can appreciate a good opening of the aortic arch. However, there are small aortic intimal flaps. Most of these flaps heal within a short period of time. We can notice that the mid-thoracic aorta, even though it shows a small intimal flap, the diameter of the diameter of the mid-transverse arch is much larger after this balloon dilatation. Patients who have coarctation associated with severe isthmic hyperplasia will be palliated in the cath lab with a stent placement on the entire isthmic region. This is a long axial magnified view of the aortic arch after stent placement. Stenting completely relieves the gradient across the coarctation. Pulse wave Doppler after the stent placement shows that there is no diastolic tailing and the peak systolic velocities are less than 2 meters per second. The stented isthmic region and the coarctation region are seen very well in this suprasternal view. In most of the patients, stenting of the coarctation completely relieves the aortic gradients, and the pressures between ascending aorta and descending aorta will be similar after the procedure. Whenever the post-stent arch gradients are measured, if the mean gradient is less than 20 millimeters of mercury, it indicates absence of a clinically significant gradient. Coarctation of aorta needs a very high degree of suspicion and a detailed echocardiographic evaluation. The presence of associated lesions may change the mode of presentation. If there is a large ductus arteriosus, or if there is a left ventricular systolic dysfunction, or if there are extensive collaterals between the ascending and descending thoracic aorta, it may substantially reduce the peak and mean gradients across the coarctation. Correct echocardiographic assessment and classification of the coarctation into type 1, type 2, type 3 will aid in planning the treatment of coarctation.